Not so much a question as a comment. I'm just sort of stunned by the breadth and the comprehensiveness of both of your talks. Actually, Bob, I said to Bob right after his talk privately that I thought he did an outstanding job of synthesis in terms of what was a long day. And you pointed to the fact, Steve, in your comments that I'm more on that number three, what can I do with it kind of thing. But sitting there and listening to the scientist talk yesterday had a lot of insight to me in terms of that issue of how to formulate it that Steve, you just so eloquently put together in terms of the importance of strategic communication. This has been just a stunning tour de force by the two of you, and I'm trying to think about very rapidly in terms of the opportunity to make a comment, formulate a question, the many rich things that we can build upon in terms of moving this topic forward. So thank you both. More of a comment than a question.
Wait, let me just, I just wanted to riff off Steve's final comment, which was about government agencies and other groups working together, and that I want to emphasize how difficult this is. So at the end of the day yesterday, we had three summary speakers, but one of them was Cora Merritt, who has just finished her term as acting director of the National Science Foundation and has had all these other roles within NSF. And she made this comment. She said, well, NIH does health, and we at NSF don't do health. We're not really allowed to do that. That's NIH's turf. And that NIH does not do education. We are allowed at NIH to do postgraduate education, residency, and postdoctoral and some PhD training, but nothing before that. And in fact, that's been re-emphasized in the last year or so, that NIH is supposed to stay out of that. Now that I'm at ARC, I've come to understand that ARC is really not supposed to be doing a lot of public health. They're supposed to be doing health services delivery. And these are all kind of parts of our charters as federal agencies. And Cora made this plea. She said, in government we can't do much of this, but you people on the outside can help get this message out that it's remarkably important for us. On the Education and Health Initiative, we went down and spent a fair amount of time with people in the Institute for Educational Sciences, very, very good group of people that does trials in education. And I think we may have been the first NIH people that actually had ever come down to meet with them, according to the people we met with. So this is, I think, a profound problem.
Could I? And then Debbie, we can get to you. The result of that, I was struck by the same comments, is that the status quo of the bureaucracy is only going to allow for incremental change. So most of the conversation yesterday was, well, we could add these variables onto our surveys. But the plea I would make to the Population Health Roundtable is the agenda for the roundtable can only be achieved through transformative change. So the roundtable can be a voice for bold steps in maybe politically naive proposals, but bold steps that I think without that level of seriousness, the U.S. health disadvantage that was talked about in our report will not change. We will continue to die earlier and have higher disease rates without those kinds of bold transformative changes. And they need to be carried over to our federal agencies and so forth, but it would require a message from leadership. The other point I want to make to finish my thought about strategic communication is that we've learned through our visits to the Hill and other places, and those of you who work in this policy space know what I'm talking about, is you got to know your elevator speech, right? So you've got a minute to make your point. And it was very instructive yesterday when we had a small breakout group and we were talking about all these different opportunities in early childhood education. When I posed the question to the NICHD staffer who was leading our small group and who said he had spent many years in the field and knew all the studies. So what are the top evidence-based treatments for early childhood to change the trajectory in early childhood? Say you're, and I tried this 2 or 3 different times in that small group, say you're on the Hill and you're testifying in a hearing and you've been asked by a senator who says, We know for prevention for Americans who are 50 and older that early detection through cancer screening is important, and we know that mammography and colorectal cancer screening and so forth are the leading evidence-based strategies. What are the leading evidence-based strategies for the 0 to 3 age group? Not the early childhood education thing, we know that's beneficial, but for the 0 to 3 that you're saying is such a vital period, for those first 1,000 days that you're talking about, tell us and our committee what the NICHD or NIH literature tells us. And it wasn't so much the fact that we probably don't have all the evidence we need to answer that question. It was how difficult it was for our small group to even come up with an elevator speech. People were sort of uncomfortably saying, well, you should probably read to your children. Other people were making some other suggestions, but it clearly wasn't something they had an instinct for how to answer. I think we need to get better at that.
Thank you for your comments. Actually, mine really builds on what you were saying, Steve. One of the reasons the roundtable got together was to really focus on actions and be very action-oriented. So I wanted to get your best thinking on where do you think this roundtable could really add value to what's already going on? You're doing a lot of work. Jeff Levy and Rochelle Davis is now doing some work in this whole area between health and education. What is it that you think this roundtable should be doing in terms of concrete things? Give us some of those bold steps that you want us to take.
Well, I want to be conscious of your time limitations. So I think part of it I mentioned earlier. Fair enough. Touche. So the vision, the bold vision is, first of all, just as to, like I talked about earlier, that is to clearly make a call for transformative change. But the other opportunity I think the roundtable has is helping to align people with the recognition of their shared. What did the word you used was co-benefits, or was it you, Dave, that said it? Which I often say is win-wins, but we're talking about the same thing. Helping different interest groups see how they all are going to benefit from this. Dave Fleming on one of the IOM committees many of us were on before used to say that health in all policies is a bit of a narcissistic term. But if we think about how there are policies that different stakeholders can benefit from, health included, then we have a conversation where the people who are in community development, the financial community, the business community, the employers, the school systems, and so forth, all see how a collective impact strategy where we all work together toward improving not just population health, but the economy, the job market, economic opportunity, income inequality, all come from a collective strategy that yields all of those benefits. That, I think, is the sweet sauce. I think the mistake we've made so far is because we're balkanized and siloed, is we focus on a public health intervention and they're over in their field working on their sectors, and helping to have a cross-sector conversation, being a facilitator, a catalyst for bringing them together and recognizing where these aligned incentives are, I think is a real opportunity for the roundtable.
And I have a question also.
Thank you, gentlemen. That was terrific. So thinking in terms of the roundtables, conversations about building movements, and thinking that movements don't always come top down, but they come ground up, and thinking, Steve, about action, if you were to get a community group together, what kinds of counsel would you give them besides voting for more money for their schools? Are there concrete things that are coming out of your experiences in Virginia that might guide what might be done at the community level to improve the educational experience?
So thank you for the question, Martha. And in the principles I just outlined that I think work at a national level discussion like we're having now, also work at the community level. And you know, Tip O'Neill's wording is probably where more of the action is at the community level. So we take it right down into that neighborhood you just saw in the video, where we have an initiative right now, just as an example, that involves residents of public housing who are the 2 out of the 4 public housing units in a 1-mile radius are slated for redevelopment. So we've initiated an initiative where we have the residents of those communities engaged with the housing authority, the developer from Boston who's come into Richmond to do this redevelopment work, the public health leadership in the area, the health systems who have done hotspot analysis and identified that most of their admissions are coming from the people living around those public housing units, the Urban Institute, which has the nation's leading experts on public housing, all working together to think about, okay, here are evidence-based strategies that other communities have found effective in improving population health for people in public housing. Let's engage the community members and the developers in coming up with the strategy. The mayor, the city council are all on board. So it's aligned incentives.
Just one more. I'm sort of really drilling down in the education sector. You're
Sorry.
talking about a broader thing, and I'm sort of thinking more about what concretely one might do in a community to bolster the education.
Okay, so a plug here for Lori Brantman again. So we've been in conversations with her. You'll hear more about her work. So I don't want to steal her thunder, but initiatives like the one you're going to hear about from her are being considered in how we would replicate that in Richmond. And we have brought into conversation the head of the school superintendent for the school system, the Department of the School of Education at our university, education leaders. But again, the same stakeholders I just talked about regarding public housing have identified education as a priority. So the three health systems that normally never talk to each other because they're in competition with each other have come to agreement that they want to do something about early childhood education because they've done the math and figured out that that's important to them. The community members in the public housing units have said that parental involvement and parental support, you'll hear more about that from Lori Brantman, is one of their top 3 public health priorities. And the second of the top 3 is workforce development, which is their term for getting a job and economic prosperity and so forth. So my point is we have an alignment of incentives around education. It doesn't happen by accident. It requires a proactive effort to bring these parties together and facilitate and catalyze a conversation like that. It can happen at the local level, and it's happening all around the country, but I think it also needs to happen at this level too.
Let me just say, Martha, that education, I think, is a real challenge because that you have no choice but to go local. Just, federal education policy doesn't mean much because the authority is delegated to states and within states all the way down to school districts. And so you have local school boards who have a lot of authority, all of them acting quite independently of one another in many states. And so this really is a local challenge.
So now I have a question. I liked your awareness, insight, action sort of framework. And I thought the first couple slides, Bob, that you showed, which shows the relative impacts of education versus some of the traditional other interventions that are more clinical, was very persuasive, actually. I can think of using such a slide with some of the people that, like board members and senior executives without a science background, and then posing the question of what can we do about this and what our perspective is on this as a healthcare delivery organization. I can imagine that in a way that actually Dave Kindig's work at Wisconsin and that slide of the relative importance of health determinants has been very persuasive to civilian audiences, non-scientist audiences. So what would be, and maybe Steve, you would say your center already has this material on the website and I need to go look at it, but what would be the 3 kinds of things that you would recommend? Would that be one of them? Would there be others in that elevator speech in terms of awareness? And then moving down it's a complex question. So then the second part of it is moving down to the action part. Do we need a synthesis of the available science that Bob's group so carefully, laid out in terms of where we are? Would that come from the CDC? Would it come from AHRQ? Would it come from the education silo? How would we put together a structure that gets us the syntheses of this science that then can be used in an authoritative way by who I call civilians, non-scientists, non-experts, in terms of formulating policy or allocating resources.
Sure. So my first response to that is at all three of those levels, we should not make those decisions. We need to do what is the equivalent of market research, and go to those audiences to figure out what they need, rather than us in this room or in a similar kind of academic context say, oh, we think they need this report from the CDC, or we need this review article. The systematic review might be useful to them. Rather, let's find out from them what they would find useful and frame it around that. That's, again, market research is not something we are typically good at doing. The business world knows more about that. And at our center, we're just getting our toes in the water, learning how to do these things. So we're just, the kinds of stuff I showed you is just experimentation. We need to take the resources that we have in our field and make a more serious investment in learning from the communication sciences, advertising, marketing. I'd put a shout out to places like the Public Health Lab at Washington University, where they have people at the Brown School there who work with a school of design on how do you convey public health messages in effective ways through communication. There's a similar group in Texas at UT Austin that's also working in this area. And so for the first level audience where you're just trying to raise awareness, how do our new kinds of social media and other technologies that allow us to really present concepts in a cool way visually that convey an idea in a matter of seconds, which have been mastered very well by advertisers and others, how can we learn to exploit those capabilities to make this connection? For the second audience, you look at the very good infographics that appear, for example, in your Washington Post or New York Times, whatever, that are able to take large amounts of data and present them visually in a cleverly designed infographic to make the point, can be very powerful and effective ways of helping people appreciate this. Interactive tools on your website or smart device that allow you to play around with the variables and see how big an impact they have. We've started to experiment with this, but I think there's much more that could be done. And then on the third level, the more sophisticated audience that's looking for recommendations on what they ought to do, there in particular, I think it's critically important to know exactly what they want to know, and then package the product around that. Because often it's the other way around. They look at it and go, well, this is nice, but that's not really what I need to know.
Thanks, Dave. And then I think Jerry first.
Thank you for your presentation. I was struck by, Steve, by your comments about in terms of educational attainment and choosing healthy neighborhoods. Work we're doing in Greater Cleveland, doing some surveys through our health improvement planning process, oversampling in areas of particularly high need areas, hearing from residents in terms of neighborhood issues. Unhealthy neighborhoods was an issue that came frequently from residents. So I'm sort of worried about the increasing isolation issue, and wondered whether in your work in Richmond, whether school boards are involved in the community development context about neighborhood redesign or redevelopment, healthy food access, park access, whether they're integrated into some of the work that you're doing in Richmond, and to what degree?
They are to some extent, but not to the level that I've seen in many other communities. Yours might be an example of one that's that's further along. But I think in many communities around the country, there is this very exciting cross-sector collaboration. Some of it stimulated by the CDC's community transformation grants that really fostered this kind of cross-agency dialogue. But in our community and in most other vulnerable populations, the disadvantaged residents see education as their ticket out. It's how to break that cycle of persistent poverty and material deprivation that exists in so many neighborhoods around American cities. Education is the exit ramp to get out of those neighborhoods and also to revitalize those neighborhoods. So there's increasing evidence. I'll just mention East Lake, Georgia, as an example, a neighborhood of Atlanta, where an intervention actually led by community developers and real estate developers and the public health folks came along, resulted in not only marked improvements in the success of kids in those schools, but a drop in unemployment rates, drop in crime rates, improved public health outcomes, and without the usual problems of gentrification where the residents are displaced from the neighborhood. So I think people are recognizing that the revitalization and economic empowerment of communities is also going to come from investments in education.
I know we're almost out of time. Let me take the last question. I, as with George, was actually stunned. I mean, I know this stuff, but the way you put it together was very compelling, so thank you. You were hopeful. Our next roundtable in July in New York is about relationships with the business community. That's what we're going to next after we finish today. It's moving along the way we do. I mean, you were hopeful about business leaders understanding not just the connection between education and workforce productivity, but maybe the health connections as well. Would you just, we don't have a lot of time, but would you say a little more about what your insights are into that, getting that understanding more fully developed?
Well, I can theorize about it, but if I only had a few seconds to talk, I would say just look at the fact that on their own they're coming to this. So you see reports from the National Business Group on Health about social determinants of health. You see work by IBM and other companies that they are talking about it. So they have discovered this themselves. But you know, for most of my career, the assumption that I've always been taught is that business people and health plans aren't going to buy this argument because the return on investment occurs so far out that these people won't be their employees anymore, they won't be members of their health plans anymore. And while that problem still exists, there are obviously the big benefits of prevention, whether it's traditional forms of health promotion or dealing with these social determinants, the big gains really do occur decades later. There is an exciting body of evidence, I think, about the short-term wins. One insight, it's not about business folks, but I'll share it, is when we met with the National Governors Association as part of this initiative, part of the feedback we got from them, because I put the question to them, isn't it the case that the governors really don't care about these benefits if it's not going to be within their term of office? And the answer was that's not entirely the case. The point was made, how many of your governors fly off to Europe or some other place on jaunts to try to drum up business to move, to bring their industries into their state? Those efforts that they're making are not going to materialize while they're still in office. So there are some of our elected officials who really are taking the long view, but politically they have to have a mix of long-term and short-term gains that they can show. They have to be interested in education or these other arguments that we're making, they have to be able to show some early wins along with making that long-term argument. And I think there's a growing body of exciting evidence about these early wins, even with kids. The population that we often say, it's hard to make the case because it's so many years before you'll see the results. When you hear Lori Brotman talk this afternoon, I hope I'm not making you nervous, Lori. And you see results that early in childhood. And if you know anything about the tracking of obesity and then think through what the economic implications of obesity are, it's not too hard to start imagining an ROI case, a business case that can be made even for the investments in kids.
Okay. I'd like to give a round of applause actually to Bob and Steve. You both set a really compelling foundation for the panels today. Thank you on behalf of the roundtable. And I was remiss when I gave thanks. I did not point out our IOM staff members who worked with us Alina and Colin, thank you very much on behalf of the roundtable for pulling this together. Okay. So now we are going to move to the next panel, and I'd like to invite the panel one speakers to come to the front and take a seat.